Good afternoon. I am going to talk on understanding retinal vein occlusion, diagnosis and management, going through some case scenarios. First case is a 54-year-old lady, non-hypertensive with non-POAG, on AGM with controlled pressures. She came with complaints of blurred vision in left eye with a visual acuity of 660, and she diagnosed with the infratemporal branch retinal vein occlusion with macular edema. And her OCT was showing significant cystoid macular edema, and actually we advised first visit itself the intravitreal anti-VEGF injection, but she was not keen on that injection, and she came on 27th of August with a slightly reduced macular edema and slightly improved vision. Again, she came with increased macular edema on 3rd October with a visual acuity of 660. And we have advised the first dose of intravitreal injection of ranibizumab, and 2 weeks post-op, she had resolved macular edema with a vision of improved 618 N18. And FFA was done to rule out the macular ischemia and see the extent of capillary non-perfusion areas. It showed an increased foveal avascular zone suggestive of macular ischemia with the inferior capillary non-perfusion areas suggestive of macular ischemic areas, and we have advised sector laser photocoagulation of 2 sittings. At 6th month follow-up, she had an improved vision up to 612 N6, and we have advised an early FFA to know the anti-VEGF CNP areas and the anti-VEGF drive, so it reduces the further need for the further injections. Coming to the RVO management, we have to manage the patient systemically as well as the ophthalmic part. Patient should undergo all routine investigation, especially blood pressure should be checked. Blood pressure is a main common risk factor in most of the patients. In patients less than 50 years, we have to advise and chest X-ray, CRP, thrombophilia screening, homocysteine and carotid Doppler. Then baseline, ophthalmic part, visual acuity, RIPD, gonioscopy, fundus photo, OCT and FFA should be done. Systemic treatment, we have to do an urgent referral to physician for control of blood pressure, aspirin, anti-inflammatory agents, systemic anticoagulation and fibrinolytic agents. This is a simple algorithm for BRVO, assess the visual acuity and OCT. If there is inter-involving macular edema, we have to advise anti-VEGF or intravitreal dexamethasone. And we have to see the monthly OCTs in PRN regimen, and we have to inject further if there is macular edema is there. Then ischemic BRVO, we have to monitor for neovascularization. Then if there is FFA, we have to advise an FFA, and FFA showing more than 5 disc diameter of CNP areas, advise a sector laser photocoagulation. And follow-up in 1 to 2 months till 6 months, and 3 to 6 monthly follow-up up to 1 year. This is a second case, a 73-year-old male with non-hypertensive and diabetes, and patient came with a gradual progressive painless diminution of vision in left eye with a visual acuity of CF 2 meter and 36, and patient actually done a pre-op evaluation and OCT showing a significant macular edema, and retrospectively patient was diagnosed as a superior CRVO with cystoid macular edema. So we have advised cataract surgery along with the intravitreal ranibizumab injection first dose. And post-operatively patient resolved macular edema and vision of 618 N6 further. Then again he had developed cystoid macular edema, and further second dose of injection was given and his vision improved to 69 N6. Then we have done an fundus fluorescent angiography. The foveal avascular zone was within normal limit and showed a significant capillary non-perfusion areas in the superior quadrant suggestive of ischemic areas, and advised the 2 sittings of laser photocoagulation. And patient responded well, and at 6 month follow-up, 6 parts N6 vision with a resolved macular edema, and non-ischemic cases showed a good response to anti-VEGF and laser. This is a detailed algorithm of cystoid macular edema with CRVO, and already discussed about this intravitreal anti-VEGF injection and steroids. And there is for steroids there is a risk of cataract or glaucoma. Monthly injection should be advised in PRN regimen. If there is resolved macular edema, FFA should be done. If more than 10 disc diameter of CNP areas, we have to advise sector laser. If there is non-resolving macular edema, we have to switch the anti-VEGF or steroids. Then we have to do an gonioscopy at 3rd month. if to see the angles, open angles, and neovascularization of angle is present with the normal IOP, urgent anti-VEGF and PRP should be advised. With closed angles and high IOP, NVA is present, topical and systemic AGM or tube shunt surgeries can be advised. And sector laser or antiretinal cryo depends on the media visibility. Then this is a neovascular glaucoma algorithm, might be knowing. With acceptable visual potential, with clear media, anti-VEGF and PRP. With media, HAZE is the management of IOP along with PPV and anti-VEGF with PRP. If there is poor visual potential and painful blind eye, diode cyclophotocoagulation or evisceration in persistent pain. Then anti-VEGFs, ranibizumab and aflibercept are the common one we are using. Monthly injections are given until maximum visual acuity is achieved and no signs of disease activity are present. Coming to the prognosis, visual prognosis 20/60 or better, vision likely remains stable. 20/80 to 20/200, variable outcomes may improve, stay stable or worsen. Worsen 20/200, unlikely to improve. In ischemic cases, the prognosis is variable due to macular ischemia, and neovascular glaucoma risk is there in 50% of cases due to rubeosis iridis, retinal neovascularization in 5% of cases. Complications are macular edema causing vision loss, vitreous hemorrhage, and neovascular glaucoma. Follow-up recommendations in non-ischemic cases every 3 monthly for first 6 months, ischemic cases monthly for 6 months, then every 3 months. Extended follow-up for 18 to 36 months based on treatment response. This is another case of a 49-year-old male, non-hypertensive, with a blurred vision in right eye, 660 N24, and diagnosed with a supratemporal branch retinal vein occlusion with macular edema, showing significant cystoid macular edema with a central macular thickness of 631, and first dose of intravitreal ranibizumab injection was received. 2 weeks post-op itself, showing significant reduction in macular edema. Central macular thickness reduced to 241 at 2 months post-op. And patient had a 612 N12 vision, and FFA was showing increased foveal avascular zone suggestive of macular ischemia. We have advised sector laser for 2 sittings. Better and faster outcomes in younger and non-ischemic CRVO patients can be seen. This is another case of 49-year-old male, non-hypertensive, with a visual acuity of 6 N6 parts, and patient diagnosed with a CRVO. And for this patient, it was a younger patient. We have looked for the homocysteine level. It was 17. It was slightly elevated, and physician consultation was done and treated with vitamin B12. The patient clinically improved within 4 months with improved visual acuity. This is another case of 72-year-old female, non-hypertensive diabetes, status post cataract surgery. It was an old CRVO with a CME in left eye, status post injection in 2022. She had a visual acuity of 624 N12, and she wanted to know whether to do anything for this case. On examination, she had opticociliary collaterals with some exudates in the perifoveal area. OCT was almost normal. And FFA showed a leakage at disc and perifoveal area with increased foveal avascular zone and significant capillary non-perfusion areas. In view of CNP areas, we have advised a prophylactic PRP. Her vision improved by 1 line. Then this is a newer anti-VEGF, faricimab. Faricimab is a dual angiopoietin-2 VEGF-A inhibitor. Phase 3 trials are going, Balaton and Comino trials. The outcomes are non-inferior visual acuity gains to aflibercept, greater reduction in macular leakage, and comparable safety profile to aflibercept.